All right, we are now going to begin our Ask the Expert session. I'm going to invite to join me here several of our experts, and we're going to answer some of the questions that people have provided over the previous days, as well as provided today. If I can invite Dr. Okuno, Dr. Vesel, Dr. Wilky, and patient advocate, and Dr. Weinberg, please. If you could all join us on video and audio, that would be great. And as you're coming online, let me start asking questions here. The first question that's come up is, how do I know if my EHE is an aggressive type or not?
I can start with that one. Hello, everyone. I'm Breelyn Wilky from the University of Colorado. And again, it's such an honor to be invited to talk with all of you today at this incredibly important meeting. So one of the first things that I always talk with patients about is how different everyone's EHE is, and how it's so important to understand, the individual tumor and the individual patient and the biology as those two things interact. We don't always know right up front how aggressive the disease is. Many times patients are diagnosed when they have a scan for some other reason and maybe not even having symptoms. They may feel perfectly fine. On the other hand, some patients will have significant symptoms and then wind up getting worked up and found to have the disease. So it's a little bit of a puzzle for most patients. And usually, assuming that people are in a pretty good shape, we'll actually use scans. We'll use radiology to tell us what the tempo is of the disease. And that might mean somewhere between 3 to 4 months between scans to kind of see if things are growing in the setting of not having symptoms. If you have symptoms, then of course we kind of assume, that the disease is active, at least to some degree. And I'm more likely going to offer some kind of treatment with that. Dr. Okuno, or what do you think?
No, I agree 100%. It's one snapshot in time. And then from there, you have to move forward and see what happens over time, unless you have symptoms already. So that's usually what happens. We did hear a little bit too, the type of EHE might indicate how people might do, but as Dr. Wilky says, every individual is different, and not every EHE kind of plays by the rule book, as we would say.
So I'm going to go out on a limb here and just modify or add to the comments a teeny bit. You just heard in a very nice video from Jane Gutkovich a mention of Cynthia Pollock. And about 10 years ago, I took the information from her online registry, 200 plus patients, and sort of collated symptoms and organ involvement, and in an attempt to establish a sort of a different classification system for EHE, because it is a different type of cancer from a run of the mill. And so I came up with using Meyer-Kaplan curves, looking at survival over time. The one thing that seemed to really more than anything define whether the tumor or the disease was aggressive wasn't so much the number of organs involved or the tumor burden per se, which would be typical for standard cancers. That's how you stage them, where it is, how many places, and how aggressive it would reflect how aggressive it is. But in EHE, it seemed to be more whether the disease was contained. So disease in the pleural space, disease in the abdominal cavity, like ascites or pleural effusion, usually were very indicative of more aggressive disease. Whereas patients with disease in multiple organs could have very similar outcomes to patients with very, very limited disease. In other words, it wasn't particularly aggressive, as long as the disease was discrete and contained, in single, in nodules, lesions that were discrete and contained. So that's kind of the way that I would discriminate between aggressive versus not so aggressive disease. Just my 2 cents worth.
And we did get a more specific question on that same topic, which was asking, when we're looking at aggressiveness, how important is the size of the tumor? And specifically, like 3 centimeters larger, is there any issue there, and where size is determinative?
So I think size is determinative if it's in a location that's where size really matters, right? So if it's compressing a spinal cord, or if it's in a tight space where size could really be a problem, that's not indicative of whether it's aggressive disease, but certainly whether it might need to be managed more aggressively. But there are patients who have very, very large tumors in the liver who do quite well after IRE or liver transplant.
The next question that came in is, and this is for everyone, are you aware of any lifestyle or diet, and they mentioned particularly keto, changes that can help fight or manage symptoms of EHE?
I think I get asked that question by every EHE patient that I meet. So there's so much out there on the internet, and it's so hard to sort through what information is backed by science and sort of controlled trials, and actually things that make sense from a mechanistic standpoint. So it's very tricky to do any sort of study to control for that. I will say that just from experience and in talking with a lot of patients, patients that have sort of the EHE pain syndrome, to where they constantly feel achy, or they have pain maybe not even anywhere close to where their tumors are. Some of my patients have had improvement with various ways to try to cut down inflammation. And, I think of it as medications like anti-inflammatories, Celebrex or Celecoxib, really. But then also sort of these anti-inflammatory diets, which what does that actually mean? What I tell people is avoid the processed crap, right? Because we know that's just bad in general. If you're eating more whole foods, meaning things with one ingredient, or as Jillian Michaels, the famous fitness person, says, if it grows in the ground or if it has a mother, then it's actually a legit food and probably healthy in general. And so many of my patients who adopt more of the clean eating or the whole food type eating feel better. And I don't know how much of it is directly from the disease or just nourishing your body.
I'll just follow up with that. Recent papers on different diets, keto diet as well, really are so I'm on call. So I have to kind of be prefaced to say is that whatever you do, it's probably not what you eat or what you didn't eat that's going to cause too much. However, if you do eat a healthy lifestyle, live a healthy lifestyle, if and when you do need treatment, you're going to be in better shape to tolerate it. So it's not because it doesn't mean you just go eat whatever you want and gain 150 pounds and you have kidney problems, liver problems, high blood pressure, have heart attacks and whatnot. No, those individuals are not going to be able to withstand just in general the typical things. But as we say, is that there is a lot of information about keto diets, quote, the anti-inflammatory diet, but does it really impact the natural history of the disease? It's still unknown.
And I will say just quickly, so Brian Van Tine is a good friend and somebody who studies metabolism in sarcoma in particular. And, he loves showing these super complicated biologic pathways that you might remember from high school biology way back in the day, and then promptly tried to forget about them unless you went into science. There you go, right there, exactly. So the take home is that your tumor cells will always find a way around what you give them, right? And so, like the idea of cutting out sugar completely is really, really hard on your body. You drop a lot of weight and your body, winds up, taking some of its proteins at times. And even though, it may seem like you're doing something that's going to change the environment of your body, the acid-base balance, for example, your body's got all these systems to regulate that. So trying to drive the tumor cell into one way or another of behaving is just incredibly challenging. And like Dr. Okuno said, the keto diets can be rough on the kidneys. We need healthy kidneys for treatments, right? And so all of those things kind of play in. Dr. Vesel, have you come across this in your practice?
Yeah, we come across a lot about what should I eat, what should I not eat, and some patients get extremely preoccupied and just get confused, and they don't want to eat anymore because everything seems to be threatening. And I agree with you, Dr. Wilky, that using common sense is what we tell them, and noticing what makes you feel better is what is important, and let the treatment of cancer in the hands of a clinician who is caring for your cancer. Saying all that, I think that active participation in caring for yourself when you have EHE is extremely important, and take something into your hands so you are not relying only on your treatment clinician, but you are contributing. We have a lot of patients with pain due to various reasons who feel that the diet that you are recommending or you were suggesting, simple diet, as simple as it gets, unprocessed diet, perhaps vegan or vegetarian diet, they feel much better and their pain is better controlled. But I think it's a moderation. It's really, if you decide to eat a little bit of everything, do a little bit of everything, but not overdo it.
The next question we have is one basically looking for hope in the future, and asking about the potential for hope. So the question came in as someone from the community indicating that they gather a lot of their information from support sites. And in looking at those support sites, they notice a very quick decline in patients that have EHE in the pleural space. And understanding that there are limited treatments available today, the question is, what do you see on the horizon that may be available to treat EHE patients with cancer in the pleural space?
Yeah, I always tell people the support groups are wonderful, but at the same time, just seeing how other patients are affected and becoming involved and part of those stories can be really, really hard. So again, in moderation, I think these sites are probably the best way to, to have that support, but also recognizing that sometimes you need to take a break and step away. I'm filled with hope for the future for EHE, and I think Jane Gukovich's video was just incredible, right? I mean, I met her about 8 years ago when she was first leading the charge against to drum up research and to get doctors on board. And how many researchers were on the call yesterday? It's incredible what she and others, all the pioneers of this foundation, have been able to accomplish. We've got mouse models now in the labs. We've got clinical trials specifically for EHE, or at least, where EHE, progressive EHE like that are eligible. We're going to move the needle. It's hard. And, we certainly all have patients that we just ran out of time. I think that's one of the hardest things I have in treating with these patients is some of them we just run out of time. But I do think we're going to have new treatments and more effective treatments over the next years.
Another question we have coming in here is when getting to the issue of when to initiate therapy in patients, especially with indolent EHE, and then getting a little bit more in the weeds, is the answer to that differ depending on the location of the tumor? What are the factors that are considered there?
I'm happy to keep chatting. I think Dr. Okuno had to take his call, but please jump in.
Oh yeah, please do. Yeah, if he's on call, absolutely.
I don't know. I don't want to monopolize the babbling here, but so again, I tell people if your disease is indolent, it's not like I have the magic bullet sitting in my pocket right now, right? And if you can wait, if the longer you can wait and actually stay healthy and stay with controlled symptoms, it gives you time for this research to catch up to where hopefully we'll have a treatment where I can tell you, this is likely to work in your disease because of X, Y, and Z, right? And that research is going on. So time is so important here. But jumping into a therapy that has modest activity, at least if you put everybody with EHE together in the box, it's hard. And if you don't have symptoms, I think the best thing we can do is just bide our time and hold up. Now, if you have symptoms, I think that's the driver. And we had talked a little bit about that earlier. And at that point, normally I'll wind up talking about initiating treatment. And certainly if disease is obviously growing quickly, or we start to see any indication that those danger zones like the pleura, the abdominal cavity are involved, then that may also be a trigger.
If you don't mind, I'm going to interject one more time along these same lines, just backtracking a tiny bit about the issue of hope. And, you know, it's very jaded and obviously, you know, old saw to say, you know, how important hope is. But I'm just going to relate two important personal experiences that really, I think, bring that home for patients and their families. You know, when like virtually every single EHE family out there, our son was misdiagnosed again and again and again before we actually had a diagnosis. That's, you know, that's sort of the standard road. It's such a rare disease, and before Dr. Rubin identified the causal chromosomal translocation, it was not so easy to make the diagnosis histologically. And so when we were first given the diagnosis, it was an incorrect diagnosis, and they literally gave us no hope. It was on a Friday, and they told us there was actually, he was not even going to get a port because the disease they said my son had was untreatable, and it was widely metastatic, of course. And I would say in the case of EHE, I prefer the term systemic because metastatic carries a different connotation. But it was so severe and so widely metastatic, there was no treatment. So that was, I don't know, 15 years ago or something. Now my son is in a PhD program somewhere. So they were wrong. And when I got the real diagnosis and saw that this is a disease that can be indolent and can be associated with long life, that gave us a ray of hope. And that hope is everything for patients, whether it's EHE or not, but especially for EHE patients, I think. So that ray of hope really does matter so much. And years later, I ran into a brilliant scientist by the name of Marius Soudal, who is really was a leader in understanding certain types of protein, and including proteins that are involved in EHE. And he said, Guy, I just want you to know, and this is just a few years ago, there are really tremendous advances right now in understanding, you know, signaling pathways involved in EHE, and we will have an answer to this disease before too long. And I think that there is a lot of truth in this in terms of what the science has achieved over just the last few years, including, of course, as Breelyn mentioned, the 2 animal models that we have now. So I'm just going to leave that. So that was my little 2 cents worth on hope for the people out there, and I'll leave it at that.
I'll throw Nicholson's in there as well, and just to follow up on that. Any cancer doctor or oncologist should never quench hope. Whether it's advanced disease, rapidly progressing, there's still hope. The hope is that whatever time one has, that you're going to live a quality of life, whether it's quantity, those are the decisions that all of us are having. If you find an oncologist that quenches all hope, that becomes a challenge. It's not unique to EHE. You clearly want to make sure you have the right diagnosis and understand. Breelyn and I deal with a lot of individuals with desmoids, which are not malignancies, but neoplasms. And those are individuals also that we kind of do a watchful waiting. And that is a big deal. And we don't give up hope that in those individuals, and it's very, very similar to the EHE community as well. So you really have to say there is hope. Even when all treatment options are limited, even when all physical signs and symptoms are leaning towards otherwise, there's still hope. We can't forget that.
Well stated.
Yeah, thank you much. Actually, a series of questions came in that related a little bit to something you just said there, which is, you know, making sure we get the diagnosis correct. We received several questions about the degree to which one ought to have molecular testing or histology done, and, you know, if their doctor tells them they have EHE, what ought to be in their record, and then what do we do with that information? If you have some comments on those topics, please.
Yeah, so I think, definitely you want to have your pathology reviewed. If you get a weird diagnosis like this or any sarcoma, it needs to be reviewed at a specialty center or a place with high volume for sarcomas. And the reason is that the diagnosis will change. I think it's something like 30% of the time when it's re-reviewed. The figures vary. That's the first thing. For EHE in particular, it can be very difficult to distinguish EHE between benign overgrowths of blood vessels or hemangiomas. And there's about 8 different pathology terms for all the different things that could possibly be goofed up with your blood vessels. On the other hand, you could have a full-blown angiosarcoma, which is also a totally different beast with very different treatments and prognosis for that matter. So that the fusion testing or the IHC, which is immunohistochemistry, the staining, is now being used more and more to seal the deal. And the nice thing is EHE is really defined in general by those 2 fusion proteins that we know are out there. And so that instills a huge degree of confidence if you do the fusion testing. For getting additional molecular testing, like the whole genome mapping or to look for other things that are broken, I've done it for a few patients, and in my experience, you will come up with a couple of things. I had one patient that also had a CDK2 loss, which is a random gene, but it did actually point us towards trying to treat with a different drug that is designed to counteract those effects. But in general, I usually I find the fusion and not a whole lot else. So I think if you're looking for clinical trials, if you're going to be complete, and certainly if you didn't have the fusion testing done originally, sometimes the whole genome testing makes sense. What do you guys think?
I'll just follow up on that. You want to make sure you got the right diagnosis. And we've heard from Dr. Rubin, Dr. Sanescu, and the team, let's make sure you get the diagnosis. And you probably can get that fairly quickly with immunohistochemical staining. The next level is the molecular testing, whether you do it in-house and do 1,000 genes, whether you do a full exome genome, which a lot of research areas are doing, whether you send it out to a commercial vendored product as well. Those are all opportunities, and you might stumble upon it. As an individual clinician, that's not going to be that helpful. The strength that we have as a community is if all 200, 300 patients every year submit to the biobank or submit to Dr. Sanescu to kind of do the full deep dive. And then you can start to pick up the things that she's picking up on the cardiac specific mutations, okay? Whereas, onesie-twosies is not going to do it. It's the international community that's going to be able to help for that. So I kind of agree. Looking at it, it looks like EHE, but generally you want to confirm it with some type of additional testing. Certain people almost mandated to get on a clinical trial. We did that with the trametidine study. You can get in, but you had to be confirmed with FISH just to make sure you did have that translocation. And then more importantly is once you get it, is there prognosis? And we heard from Dr. Weinberg, it probably does. It kind of leans us into one direction, but it doesn't mean you as an individual are going to have a good or poor outcome depending on that.
All right, we've got one more big question here, which is a collection of a bunch of small questions. We get dozens and dozens and dozens of questions all of the time about what about this specific drug? Under what circumstances would this work? Would this work? And they're all very, very good questions, right? They're very important questions. I know they're hard to answer because the answer is oftentimes it depends. So let me ask it in a bigger frame to hopefully address as many of these dozens and dozens of questions as possible in the time we have remaining. In terms of the options available for patients at different stages, metastatic, indolent, and all of the hard challenges about the menu of options, none of which are perfect, and obviously we're hoping for better things to come along. What are the, as a expert, as a doctor who might see these patients, how do you answer the questions? What about this drug? What about this drug? What should we do for me?
Scott, you want to lead off on that? I've been babbling the whole time, so
well,
I'm turning it over to you.
Well, I can start with this, and that we then go from there. We would love to have prognostic therapeutic testing that says this certain mutation, this certain protein, 100% reliably predict that this individual is going to respond to this drug. We don't. That's the problem. So then it's going back to your expertise, what's been published in the literature, what you've seen in other patients, what your colleagues have seen with that. So if it's a slowly progressive disease, we might then discuss, here are some therapies that have certain side effects that are generally well tolerated for longer duration. Given your symptoms of a lot of pain and agony, we might suggest a more toxic regimen that might act quicker, might act faster, but we're going to get in and get out pretty quickly here, partly because of your clinical course. We would love, maybe Breelyn knows or other people know, we have that magic blood test that will tell us that, nope, you got to do the insulin treatment first, or trometidine first, or eribulin first, or paclitaxel or Doxil, or no, this is just going to be slow growing. We don't have that. So until we get that, it's really going to be based on the symptoms, and you as an individual working with your provider to say is, what level of side effects am I willing to potentially go through to get that gain? Breelyn, I don't know how you think about that as well.
Completely agree. It's and there's definitely no one right answer for every patient, and there's so many things that go into those decisions. Logistics, right? Is the patient working full time? Are they on their feet all day, making some of the oral chemo pills less appealing? I mean, the nuance that goes into picking a treatment and when the right time to start treatment is we could talk for hours on how we do that. What I typically do is, first and foremost, I say, okay, we need to, if we decide we need to treat, are there trials available? Because at the beginning, like that's the only way forward with this disease is getting patients in EHE trials or trials that make sense. So many people are interested in the immunotherapy question, but it's very hit or miss, and we need clinical trials to tell us that. So we look for trials first. If not, then we kind of move down, just like what you said. So for a lot of symptoms or a EHE that has some evidence of something called dedifferentiation or more bizarre appearing, more aggressive appearing cells, then sometimes we'll reach for those chemos and hope that it's more on the angiosarcoma spectrum. It's more in that entity. I like chemo pills in general. My TKIs are my best friend, which are medicines like pazopanib or the mTOR inhibitors, sirolimus and everolimus. Those are the mTOR blockers that I'm sure you guys heard about. I mean, I reach to those probably first before anything else for my run-of-the-mill progressing, but not quite an emergency EHE patients.
And then just a quick question on this, bring Dr. Vesel into this. How do you deal with this complicated calculus when pain management is brought into it?
Thank you for including me in a pain management. We work very closely with oncologists, and the rest of the team. But these patients require close attention. And in fact, the pain varies and moves around, and intensity goes up and down depending on the disease and treatment and where they are. So being very dynamic about the medications, including going up and down, rotating, being inventive, re-looking at the medications and bringing them back 6 months, 9 months, 2 years later is our experience. So being dynamic and being involved for a longer period of time so the patients trust you as a pain person, as well as oncologist. The other thing that I mentioned in my presentation, bringing personhood into this and learning who the person is with an illness and strengthening where their strength is what is very, very important. And that's where the hope comes in as well. Learning what are the coping strategies that work and strengthening those coping strategies and minimizing the strategies that are bringing more catastrophizing elements. So really working either with a psychologist or palliative care physician or mind and body therapist is extremely valuable, so the patients can endure at times increased side effects of the therapeutics being involved.
And we're at about time here, but Guy, do you have any sort of summarizing thoughts on everything we've talked about here?
You know, I do, and if you don't mind, I'm going to throw out one little quick question at the very end myself for these
Please.
amazing experts. Okay, just looping back with Dr. Okuno's comment and Dr. Vesel's comments about, especially hope, and Dr. Wilky's comments about, selecting the drug. The knowledge that we have about the signaling systems that are altered in EHE tell us that the mutation that affects the fusion gene all funneled down onto one targetable location. It's a transcription factor, a family of factors named TEAD, T-E-A-D. That means that there's a hope that in the future we would have that one protein, targetable protein, that we can generate an effective treatment, preventing the interaction between the TAS-CAMTA fusion protein and that transcription factor. And that would be sort of that's the Achilles heel of this disease, which is clearly addicted to that mutation. So there is real hope. If nothing else, we know that the drug companies, by recognizing that TAS is involved in lots of different cancers, see money in those hills, and they are going after that interaction, the TEAD interaction, and there will be medications designed to do that that'll be useful in EHE. Now, my quick question for the oncologists: what do you guys think about just putting people on statins based on what we heard yesterday and what we know about the basic science behind mevalonate and chemistry and inhibiting TAS activity upstream with the use of statins, since it's great therapeutic index?
Yes, I think I unfortunately had to step away during that section of the talks, but I do plan to go back and listen. I mean, this is sort of a great example of like the drug repurposing type of study that the FDA is very, very keen on learning more about. And whenever we can bring data suggesting that more commonly used drugs for other things can be repurposed, they get super excited. So, I think, again, it's one of those things where it'd be great to try to do a collective study with patients and using a novel approach where maybe the patients don't necessarily have to be treated at a central facility, like trying to break down some of these barriers for patients to get to trials. Something like that might be incredibly interesting. Obviously, statins can be tricky if you're combining with other medications. And so I think I tend to avoid them for people that are on particularly hepatic or liver metabolized drugs. Just because, again, they can cause inflammation of the liver and change metabolism and absorption and things like that. But I think it's a great question and one that would be amenable to that type of trial.
Thank you.
Agree.
Thanks, Scott.
All right, we're at time now. Great session. Thank you all for contributing your time on a weekend for this very important conference. And with that, I will turn it over to Jenni to wrap us up.
All right. Thank you so much. Wow, that last session was amazing. And hopefully all of you are feeling a little bit more hope today than maybe you had this morning or earlier. Because I know that I am. I actually got pretty emotional during that time because I'm excited. I'm excited to hear some of the things that were shared today and excited to hear amazing, brilliant minds tell us that there's hope. So I want to thank the researchers and the clinicians that provide their time fighting EHE. I want to thank our patients for amazing engagement and being advocates for EHE care. I'd like to go back to something Dr. Rubin mentioned earlier today, that there is no treatment without research. And something I did not know until I was diagnosed with EHE is that research costs a lot of money. It is expensive. So I just want to say thank you to everyone who has financially supported EHE through donations, personal fundraising, events, buying t-shirts, and all the other creative ways that this community pulls together. We hope that today shared some of the impact of your dollars. None of this can be accomplished without the support of our community. There are many ways to help further progress treatments and cure. Donate valuable tissue if it's possible in your country. Support our fundraising initiatives in the US. Those are our annual Fun Run and Walk, Giving Tuesday, or just donate directly through fightehe.org. If you're outside of the US, our sister charities in the UK and Australia and patient groups in Canada, Italy, and other countries also have initiatives that you can support. With an engaged patient community, amazing clinicians and researchers, and supportive nonprofit organizations, we have a great team in place to have hope. We will not rest until our goal is achieved. We believe that there will be a world where we can save lives because EHE is treatable and curable. So thank you to everyone for supporting our global EHE research efforts. And there's only 2 words we can use to sign off today, and that is just live. Thank you.